and today I'm going to talk about methadone treatment in special populations, especially patients with comorbid health problems. Here's my conflict of interest slide. I do some work for a few different companies. So we're going to take a look at the use of methadone and other therapies in patients with some problems such as sleep apnea, cardiac arrhythmias, kidney problems, and liver problems. And going to take a look specifically for the methadone maintenance treatment where problems lie. And there's not a lot of evidence that we have to deal with, but we'll take a look at some of these things. One of the things we're concerned about is potential safety and maximizing methadone safety. So in the US in the 2000s, there's some interesting statistics that came out. Methadone represented less than 5% of opiate prescriptions, but it was involved in about a third of opiate-related deaths. Now, you could say, well, the population who needs methadone might have a higher chance of having an overdose because they might be more impulsive or unpredictable. But we do need to show some caution that there are some specific things of how methadone works in the body that makes it a problem and potentially dangerous. That wide variation in half-life that you see at the bottom is one of those. Some people learn well by pictures, so this helps explain why we need to start low and go slow in methadone. Feel free sometimes to print out these pictures and show them to patients if they get frustrated in the first few days of treatment as to why the doctor's not giving them a higher dose. In the first couple days, the majority of methadone goes into the tissue binding sites. That's at big bucket A. And that's something that the patient doesn't feel as either analgesia or relief of opiate withdrawal symptoms. But then on the next slide, after a few days, when those tissue binding sites are saturated, more methadone goes from there into the area that's in the free fraction for plasma. And that can lead to some toxicity if we've escalated them just a little too quickly before we know just how long it's taking them to get to steady state. Feel free to show these pictures to patients. It sometimes settles them down if they're upset about why they're not going elevated quick enough. Let's take a look again at the comorbid health problems that we're going to deal with. We're going to talk about sleep apnea. We're going to talk about QT prolongation. We're going to talk about hepatitis C and just general liver dysfunction, and the same with kidneys. So first, looking at sleep apnea, there's a study done where they took some patients who were on chronic opiate therapy for chronic pain, and they looked at something called an apnea-hypopnea index. And they found that 75% of patients who were on chronic opiate therapy had a problem with this index. 40% obstructive, 24% central, and I'll talk about the difference of those two later. Some with both, which is a very dangerous one, and I guess some they got some ambiguous data on. But these numbers are quite high. So what are the two different kinds of sleep apnea? The most common one we know about is the obstructive sleep apnea. That tends to be the overweight male with a big neck who snores during the night. So the airway starts collapsing, and that's a physical thing that's happening. And usually there's a lot of snoring. The central sleep apnea is that there's something going wrong with the brain signals that tell us to breathe while we're sleeping. They may have long periods of making no effort to breathe. One of the worrisome things is it's not associated with snoring. Sometimes you'll hear a patient's family say that their relative snored a lot when he was on the other opiates, and they're so happy now that he's on the methadone he stopped snoring, this could mean that they have both obstructive and now central sleep apnea too, and this could potentially be fatal. So it might be important to help delineate that. Other studies looking at methadone and sleep apnea, there's a significant number of patients who are taking methadone who have significant sleep apnea, and this seems to be quite related to the dose of methadone. So the higher the dose, the more sleep apnea, and that's a concern, and that's why a lot of wise methadone doctors are really cautious with their dose escalations and not wanting to get too high. There's been some other studies that showed about 30% of stable methadone patients have that central sleep apnea. That's a pretty high number for people who are stable and don't think they have any significant problem. One of the worries is that the tolerance to respiratory depression is incomplete, and it's outpaced by the tolerance to the other opiate effects, such as euphoria. So if people are seeking euphoria from an opiate, they develop tolerance to that dose for the euphoria and would try and get a higher dose, but their tolerance to the respiratory depression hasn't hit yet. So that's why sometimes these things are so dangerous when people rapidly increase their opiate doses. A study done a few years ago about sleep disturbances among methadone patients. I'll just highlight some of the things on it. So a lot of methadone patients, 84%, described their sleep quality as poor. There was much stronger associations with depression, anxiety, nicotine use, pain, and unemployment. So generally, those things are associated with poor sleep quality, and I think that probably makes sense to a lot of you. And this takes a look at what people were using for sleep. So people tend to use something to help them go to sleep. A quarter of people use alcohol, and I don't have too much details in this presentation, but basically what alcohol does is it helps you get to sleep faster, but then it causes a less natural kind of sleep with the different waves of sleep, and you wake up earlier feeling less refreshed. So you may have a few drinks, fall asleep right at 11 o'clock at night, not even remember putting your head on the pillow, but by 2 in the morning, you've awakened from that alcoholic sleep. You do not feel refreshed because you haven't had the proper REM sleep, and you have difficulty falling back asleep. 14% take benzos, cannabis is pretty popular to help people sleep, and opiates people take to sleep. Of the four of those, cannabis is probably the safest one. It's the one that's least associated with respiratory depression. What's the pharmacist's role with sleep apnea? Well, usually people get recommended CPAP machines, and those are generally uncomfortable and loud machines that people don't like to use. So I think encouragement is important. Encourage your patient and educate them about why we need to start low and go slow. And remind them, caution with benzodiazepines and alcohol. For those of you who've been practicing methadone for a long time, from the mid-90s, you might remember a medication called LAM, levoacetylmethadol. And that was a precursor of methadone that could last 2 to 3 days. And in 2001, people were seeing that there was a lot more cardiac problems and a lot more sudden death, and there was a lot of QT prolongation. Europe took it off the market in 2001, and in the US, the manufacturer stopped producing it in 2003 because of this heart problem. Methadone is a cousin of it and has a similar heart problem. So people say, what is QT prolongation? And if you take a look at the very bottom, the QT interval is that part there, when the heart starts to beat to after the heart's finished that beat and is getting ready to reset for the next beat. The specifics of it don't really matter. Prolongation. And if you take a look at the very bottom, the QT interval is that part there, when the heart starts to beat to after the heart's finished that beat and is getting ready to reset for the next beat. The specifics of it don't really matter, but on the next slide I'll show you what happens if that interval is too prolonged, that the heart doesn't really get the proper timing to reset. So this is called torsade de points, literally meaning twisting of the points, and this can be a fatal arrhythmia for people to have. And this is from prolonged QT, and again associated with methadone and associated with other things that we'll see on other slides. What are some risk factors for QT prolongation? Older people, structural heart disease, low potassium levels, etc. Alcohol use can cause this, same with cocaine. And there's lots of medications that I'll show you later. Some people may report a family history. I think if people have a history of first-degree relatives dying suddenly at young ages, we need to be cautious of this. Here's some guidelines for what to do about ordering cardiograms and taking a look at QT prolongation. These are from the States, and it suggests an ECG before starting methadone, and what numbers 450 to 500 to be cautious at, and to reduce the methadone at 450. I reduce actually at even a lower level. Here's slides from the CPSO guidelines 2011, and it talks about doing a cardiogram at 150 milligrams. If a patient's risky, maybe doing it at 120 milligrams, and to look out for people who complain of a racing heart, dizziness, fainting spells. Personally, I do more cardiograms than the guidelines say, and I have been surprised at some low doses people have high QT prolongation, especially if people are on other medications, which we'll talk about in a few minutes. So I do more than what the guidelines say. Here's something from the FDA in 2011. Most of you probably remember this and use this as part of your practice, but citalopram was found to have some abnormal heart rhythms associated with it. And this, for the most part, we're now seeing is a class effect in several similar medications. In 2012, Health Canada updated the citalopram warning, and it should not be prescribed in doses greater than 40, and especially in people with liver problems or older people, 20 should be the maximum. So for those of you doing a lot of long-term care medications, you want to be cautious of this with older people who might have liver problems. here's a list, and it's a growing list, and I'm not going to go through it, but this is to show you that there are a lot of drugs that are associated with QT prolongation. What are some medications to watch for from that list? These are some that I've highlighted because they're a little more common in our people with addiction problems. And so you can see like some things like quetiapine, citalopram, clarithromycin we have to be careful about because people go on antibiotics all the time, especially when people who smoke and maybe have lung problems. So once again, we need to be cautious of this. Now, I've talked about the cautions, but we do need to be careful that it is more important that someone stays on methadone, even if they have QT prolongation, then we stop methadone and have them go back to intravenous drug abuse. So we don't want to withhold methadone treatment, but we do want to give them informed consent and make efforts to cut down. But if we cut down and they tell us that they're having cravings or they start to use illicit drugs again, then it probably is worthwhile to accept the risk with informed consent to re-raise their methadone levels back to a level where they won't be thinking and craving and using other drugs. So I do want to throw in that caution there to balance this presentation. So what can the pharmacist's role be with QT prolongation? Because a lot of pharmacists say to me that, well, we're not looking at the cardiograms. We don't know what's going on. Well, I'm going to tell you a lot of doctors don't look at cardiograms too. So it's important to alert the physician if they're on a couple different medications that it may be time to do a cardiogram. If someone's on Seroquel and citalopram and getting medications like Biaxin for antibiotics and they're on methadone, possibly a good fax or a good relationship with your pharmacist that you can call him or speak to him about it. It may be time to do a cardiogram to look for this. Hopefully physicians should appreciate this because we all are interested in our patient safety. Sometimes we may want to, if the QT prolongation is high and they're on a lot of different medications and they're having some symptoms such as dizziness, it might be time to consider a switch to buprenorphine. Those of us that are used to this and giving people buprenorphine, we know that the switch from methadone to buprenorphine can be difficult. The methadone can stay within the body for a long time, and people can have a difficult time switching over. We'd like to decrease the methadone dose to 30 before we start on buprenorphine, and usually people need to be without methadone for a significant time, a few days perhaps, before they can transfer onto the buprenorphine, but they can have a difficult time. Methadone tends to be the hardest thing to switch people from to buprenorphine. And I think it's important for us to realize that. Here's just some pros and cons of the different medications. Methadone definitely is cheap and it has coverage. Well established, lots of studies. It can be used in neuropathic pain, or there are some studies on that. Observing the dose for the pharmacist is very quick. They swallow the methadone and they're out of there. They can't inject the juice, or if they do, they get quite sick. There's a lot of side effects. There's a slower induction process. There's more drug interactions and QT risks. It is a full agonist, so there's overdose risks, and diverted doses are quite dangerous in our community. So that's the methadone pros and cons. Buprenorphine, let's look at some pros and cons. There's a lower overdose risk. The titration, if you rapidly titrate, by 2 or 3 days, the person is feeling much better. There's generally less side effects. There's less stigma. Methadone does have a stigma, and it's important that we realize that a lot of people don't want to go on methadone. On the first day, you could precipitate withdrawal, so that induction process can be a bit trickier. For the pharmacist that's supposed to observe the sublingual dose, that can take longer. I'm recording this in 2015. That comes in a film in the United States that goes in a buccal film that absorbs much quicker, and the observation dose is much shorter. As of 2015, that's not available in Canada. And something that doesn't happen as often as I thought it would is that sometimes the buprenorphine may not be strong enough. People say because it's a partial agonist in people who've needed high doses of methadone that the buprenorphine is not strong enough. And I've not seen that happen as much as I thought it would in 2007 before it became available. The vast majority of people can do fine on buprenorphine. Let's compare the mu receptor activity, the affinity. Methadone has a high affinity, but buprenorphine higher. Again, full and partial agonists. Methadone dissociates slowly, but buprenorphine is even slower. The half-life for buprenorphine is a bit longer. And those are the liver pathways that they go through. Methadone goes through 2 pathways. Comparing methadone, methadone is cheaper, although buprenorphine will soon get cheaper. They're both efficacious. Patient preference, I see a lot of people who come into my clinic who say, I'm here because I hear that you prescribe buprenorphine. I never would have come in a million years if to get methadone therapy, but I will go on buprenorphine. So I see that a lot in my practice. History of hepatitis C. 90% of people who have it don't know they have it or don't have any symptoms. 30% of people will then build up an antibody to the hepatitis C and recover spontaneously. That's up to 30%. Usually I read somewhere between 10 and 30%. 70% of people, though, do develop a chronic infection. 2% of those develop cirrhosis, which may not sound like a high number, but when you have enough patients, that is a significant amount. And of those cirrhotics, liver cancer happens at about 4% a year. People are very worried about sexual transmission. That's about 4% of the cases. So it's not common, but I would never tell somebody that they don't need to use protection. People still need to use protection, but it's not as common a transmission. There are 3 subtypes of hepatitis, 1, 2, and 3, and each of those have subtypes within it. Type 1 is generally the most common in the IV drug user. Treatment of hepatitis C has rapidly changed as of 2015 and is rapidly changing. So it's evolving, it's improving. There's dramatically increased rates of success, and along with that, decreased side effects. And there's increased oral therapy instead of injection therapy. With this comes a dramatically increased expense, though, to the patient or to the insurance company or to the drug benefit. But as I say, this is evolving, and it's evolving quite rapidly and improving. So as of 2015, I've been quite impressed at my patients who've had to go for treatment, and compared to the less side effects they have now compared to the ones who had treatment a few years ago. Let's look at opiate use in hepatic dysfunction, and I'm not going to just talk about methadone, I'm going to look at some of the other opiates. So in general, if you have severe liver disease, you need to give lower doses, and you need to have a longer dosing interval. So a smaller amount will work as well and last for a longer time because it's not being cleared. If we take a look at the different opiates in hepatic dysfunction, I got this chart out of a website called paintopics.org, but unfortunately that site just discontinued to operate, and it's unfortunate because it had a lot of good information. So when we take a look, and I'll show a summary on the next slide, it technically says not to use methadone in hepatic dysfunction. And I would say that's true if you're using it for pain, but because there's so limited choices of people who need it for addiction, we do use it, but we have to use more caution. To summarize that slide, methadone and codeine are not advised, but as I say, we want if someone has an addiction problem, we will use it with caution. Morphine, hydromorphone, oxycodone, we need to be very cautious with them. And fentanyl appears safe, but as of 2015, there was more and more abuse of fentanyl and higher risk of overdoses. So if someone has a significant addiction history, you still may want to avoid the fentanyl. What about the use of buprenorphine in patients? So a lot of it is unknown, but the plasma levels we might expect to be higher, so we might want to adjust the dose. That might be a patient that we start a little lower and go a little slower in, and we'd monitor their liver function. The buprenorphine available in Canada is Suboxone, which is mixed with naloxone. So the naloxone may have an effect on the liver as well. So you may run into some issues. Even though it's taken sublingually, some of the naloxone does get absorbed. Now let's take a look at kidney dysfunction and the use of opiates. And it's a fairly common thing because people with kidney dysfunction tend to have pain conditions, so about a third of the patients are on opiates. And if we're not sure of how the drug is being cleared, there's probably a higher risk of overdose because the kidneys are a filter, same with the liver. Here's a slide about what to use and what not to use, and I'll summarize this on the next slide. But overall, methadone does appear safe. So overall, we'd like to try and avoid oxycodone, codeine, Demerol. We want to avoid Demerol or meperidine in virtually any pain condition now, as it's shown to be quite toxic. We use morphine and hydromorphone quite cautiously, especially in elderly people. And methadone and fentanyl do appear safe. So what's the pharmacist's role with kidney and liver problems? Well, I think it's important if you know that they have the problems to alert the physician to the unique characteristics of some of these. Know about codeine and oxycodone in these conditions, and there are very limited options for them, but I think it's important to alert them. And all the more important in liver and kidney problems is a synergistic effect of different medications. So to summarize, we need an increased knowledge of methadone and other opioids when we're dealing with patients with comorbid health conditions. And the dosage considerations or alternative therapies may need to be considered when they have these conditions. Thank you very much. Goodbye.